yeah, Tom, if you could switch on, please. So Councillor Hutchinson.
Councillor Colin Hutchinson from Skirkett Ward in Calderdale.
Thank you. Councillor Ryler.
Good morning. Councillor Jane Ryler, from Home Valley South in Kirklees.
Councillor Blackborough.
Yeah, Councillor Howard Blackborough, Chair of the Adults Health and Social Care Scrutiny Board, and busy preparing for CQC this afternoon, which is scary.
Councillor Jamil.
Good morning, everybody. I'm Councillor Rizwana Jamil. I represent the Bowling and Barkrange Ward in Bradford Council.
We have apologies from Councillor Coates. Councillor Scopes.
Hi, good morning. My name is Andrew Scopes. I'm a councillor for Beeson Holbeck Ward in Leeds. I'm the chair of the Leeds Adults Health and Active Lifestyle Scrutiny Board. Thank you very much for having me today.
Thank you. We have apologies from Councillor Anderson. Councillor Rhodes.
Hello, good morning, everybody. Betty Rhodes, Wakefield councillor and chair of the Adult Health and Social Care Scrutiny Committee.
Councillor Nichols.
Yeah, Andy Nichols, Wakefield Rural, Wakefield Council. I'm deputy chair to Betty's committee.
Councillor Soloway.
Councillor Andy Soloway. I represent Skipton West and West Craven on North Yorkshire Council.
And Councillor Lee.
Good morning, Andrew Lee. I am a representative of the Appleton, Roebuck and Church Fenton division on North Yorkshire North Yorkshire Council, and chairman of the Scrutiny of Health Committee.
Thank you. And I'm Councillor Liz Smays from Kirklees Council, representing Burstle and Berkenshaw Ward. So minutes of the previous meeting then. Do we agree they're a true record of the meeting of the 25th of February 2025? Do people agree? If the committee can indicate that yes, are those okay? They're a true record, okay? We do have some things that we will be having back. So for instance, the item on specialist commissioning, we will be having information back on that item at a future meeting. Declarations of interest. Are there any declarations that need to be given at this time? If not, if there is something during the meeting, if members would please fill in the relevant form. We've no public deputations or petitions that have been notified to us, and so we'll move to item 5, and we have Ian and Jason who are attending from the ICB for this item. Which of you is going to start, Ian or Jason?
This is the Jason show, so I'll hand straight over to Jason. Thank you.
Okay, all right, Jason, over to you then. Thank you.
Thank you very much. Yeah. So thank you. First of all, thank you for the invite for the committee to come and speak to you a little bit about some of our work around cancer and the diagnosis. I believe you've received a kind of a paper from us, some information in advance. So I'll take the paper as read, and I'll just summarise some of the main points to enable more time for conversation and for discussion. But just the key points to kind of say from the paper is that that's my role in the kind of the ICB as the Associate Director for Cancer, but I'm also the Managing Director for a body called the West Yorkshire and Harrogate Cancer Alliance. So we have a responsibility to help oversee the improvement of cancer care and services across West Yorkshire, indeed Harrogate, so we cover kind of both areas. The ICB has kind of set that cancer is one of its top 10 priority ambitions for population health and making improvements. It's item number 2. And essentially what they've tried to submit is basically we want to try and make sure that we are making the opportunity for curative cancer treatments available more to patients than they were in the past, essentially to try and reflect what's really important around trying to improve cancer outcomes, cancer survival, indeed patient experience. And so a specific commitment was that around 1,000 more people would have the opportunity for curative cancer treatment in 2024. There was a case 2018-19, and there's been kind of a series of updates made in that in terms of the joint forward plan for the ICB and its annual refresh. And what I'm pleased to say is that, including unfortunately the negative impact that was seen within the pandemic era, we have actually seen 1,382 more people being diagnosed with cancer at early stages in West Yorkshire and Harrogate, which makes the curative treatment more possible. And the paper explains the relationship between the stage of cancer being particularly stages 1 and 2, and then what that means in terms of the cancer treatments which are available, the prognosis and the benefits for people. And we also kind of describe here that the long-term plan, indeed what's in the joint forward plan, really wants to go further. I think it's recognised, the fact is that, you know, in common with the rest of England, unfortunately, we're not actually at the long-term plan goal of 3/4 of people being diagnosed with cancer in early stage, but we have set an initial goal of 62%. The current rates of early diagnosis are 56%, and again, there's some variation between the places, which is explained in the paper, but again, allowing for the way in which kind of the data is recorded and updating the place are making improvements, which is good to see. And we were also as well seeing some kind of important initiatives which are kind of making progress on those goals. So, for example, we're seeing the improvements in terms of the screening availability for people affected by cancer, and in particular the expansion of lung cancer screening across the patch. We've also seen some improvements in the accessibility of liver cancer surveillance for people. Also seen improvements in the uptake accessibility of breast cancer, cervical cancer and bowel cancer screening. And we've also seen some linked innovation in those fields with respect to things such as what we call an Act Health, which is personalised text message reminders and behavioural science interventions, which are all helping to try and improve and motivate patients to both come forward with their screening when available. Also been a lot of work to try and break down the artificial barriers which might exist in terms of preventing people from coming forward, and also trying to support and make the population more aware of the signs and symptoms they should be considering and what they should be kind of encouraged to act upon when it comes forward for coming forward for cancer treatment. But it's also important to say that we think about the whole cancer pathway too, so not just the front end. So an awful lot of work in terms of living beyond cancer initiatives, and some work in terms of improving diagnosis and treatment pathways. And what I'm pleased to say as well is in terms of performance that, again, although there is more work to do to reduce variation in performance, when it comes to how quickly patients are being treated on cancer pathways in West Yorkshire and Harrogate when they're coming forward, some of our performance is the best in the country. And indeed, actually, there's a couple of our trusts which are meeting the NHS Constitution standards for delivery, which, you know, in a positive way kind of identifies them as a, as an outlier, which is, it's good to see that we are making those gains and improvements for people. I would also just point out, that's certainly not job done. There's a lot more work needs to be done. But I do overall think there's a positive picture there. What the paper then tries to describe is it describes what's essentially in the joint forward plan for cancer, what initiatives are current and underway now, what initiatives are planned, and also how do those initiatives in the appendix then span over to the early diagnosis strategy for the Cancer Alliance. And again, that also interacts with how we receive our funding from NHS England, which is to have that responsibility for a range of interventions across the cancer pathway. So overall, it's an improving picture, a lot more work to do. We are making a positive difference on health inequalities. We're making a positive difference to people affected by cancer locally, but we'd also recognise again that the 10-year plan expected for cancer later this year from government will set a kind of a further roadmap around the more work we can do to, number one, encourage people to come forward sooner, 2, support them to do so, and 3, make sure they get the best care across the whole patient pathway when that occurs. So I'll pause there, and again, I'm very happy to take any questions or to open up discussion on that line. So thank you very much.
Thank you. I'll open it up for questions if members could indicate by raising the Teams hand. Councillor Scopes.
Great, thank you very much, Jason, and thanks for the paper and thanks for recognising that it is a journey. So obviously making improvements, but more to go. The thing I just wanted to get in on, which you touched on, is around health inequalities. Which obviously you'll know is like a real priority for us in Leeds. And I guess what I was wondering, so when you read through it, so just if you start pay on Iron 1 introduction, current rates of early diagnosis are 56%, and we're trying to get up to 62%, which is great. I guess what I'm interested to know is are there any groups that were like being consistently missed, if that makes sense, to see if because 40% could be broadly across the whole demographic spectrum, or it could be all of the people in the bottom half of the decile. So that's my question. But I'm positive to hear that you think it's making a reduction. But I just want to get a bit more on that, please. Thank you.
Yes, so we do have some more detailed analysis basically, which looks at the early diagnosis trends by a few different kind of sub-parameters. So we have it, for example, where we look at it by primary care networks on a sub-geographical level. We also have the data whereby we look at it by the index of multiple deprivations group. And so what unfortunately you do see there, which is unfortunately what you'd expect to see, is there are associations between population health status and propensity to come forward. And indeed, there is a link there between the early diagnosis rate and indeed the IMD. What you also see as well is that we also look to routes to presentation as well. So we know that when patients do come forward via primary care or via elective routes of presentation, they have better outcomes when they present non-electively or through emergency care. And we also know that that patients are more likely to basically present non-electively through emergency care if they're from the lower socioeconomic deciles. That's quite a common trend across England. In terms of where that's been made a difference to, there is kind of a good example which completely flips that trend. So I'll kind of make a point of it here. In the lung cancer screening work that's been done so far, you're now more likely to actually have a early diagnosis of lung cancer if you come from the lowest socioeconomic deciles than if you're doing the highest socioeconomic deciles in West Yorkshire, because that program's been deliberately targeted at communities whereby they're affected by high levels of tobacco, smoking rates, and indeed actually the way we've deliberately profiled and prioritised that program by health inequalities. So again, overall lung cancer outcomes could be much better, but actually that's the one that flips the example. So that's one to state there. The other thing to say as well is that what we do to try and challenge that in particular is we're doing a lot of work around minority screening, minority population screening awareness. So some of that's based on socioeconomic grounds. Some of it's also based on population characteristic groups, whereby we know, again, that impacts their ability to come forward. So good examples of the work we've done. We've done quite a lot of work on screening participation awareness amongst the South Asian communities, and particularly South Asian female communities. We've also done some work on basically cervical screening acts for transgender population, with some significant variations in access and structural barriers. And similar as well, we're also doing a particular campaign around young people participation in cervical screening, because we understand that once we get people coming forward, they'll continue to participate, but actually getting them into that mentality is really difficult as the word goes. So we do a lot of focus work in those areas, Councillor Scopes.
Yeah, thank you very much for that. That's really helpful. That data, a little bit more detailed data, I'd be certainly keen to see that.
Yeah, we have to share that.
Yeah, great. Thanks, Chair.
Thank you. Councillor Hutchinson.
Thank you, Chair. A lot of the emphasis of one of the main ways in which people get referred for consideration of a cancer diagnosis depends on the index of suspicion that the clinician who is seeing them actually has. If they don't suspect cancer, then they're not going to refer a patient. And for a lot of the abdominal cancers, the symptoms can be quite varied and non-specific. It's not having a tick box of red flags is not enough. So looking at the figures for primary care networks where there's a greater proportion of late referrals, some of it obviously can reflect the levels of deprivation and other risk factors in that population, but some of it may depend on work practices amongst the primary care service itself. Given that there have been significant changes in the way in which consultations take place, there are perceived barriers to access to primary care, and also a much wider range of people, including pharmacists, who are incorporated into the primary care system. I was wondering how much awareness you're doing work to raise awareness amongst potential patients, but how much work is being done to raise awareness amongst practice staff and pharmacists, particularly in those primary care networks that seem to have a disproportionate level of late diagnosis?
Yes, so thank you for that question, Councillor Hutchinson. There's a few elements to that. So first of all, in terms of patients overall who do not present with classic red flag symptoms indicative of particular cancer, and you're right to pick up some of the cancer of the abdominal tract in that kind of setting, we do have now across West Yorkshire commissioned non-site specific service. So what that's doing is that's encouraging with specific NICE guidance for general practitioners to refer into secondary care where they have a gut feel it might be cancer, but the patient doesn't present a red flag symptom. And that service is available in all 6 trusts across West Yorkshire and Harrogate. So that's the first thing to say. You also are right to say that when we're looking at the trends around the early diagnosis rates, we cut it by a number of areas. I think I've mentioned the way we look by primary care network and by socioeconomic group, but we also look at unexpected variations in either referral rates or referral outcomes from PCNs based on the outcomes those populations receive. So what we do to try and make a difference there, that's we're doing some targeted education work and targeted awareness raising work with those practices or PCNs in those areas whereby, if you like, the population is not behaving as we would expect them to. Now, there's 2 particular factors there. We have 2 issues, one of which is in some areas we have under rates of referral. So we essentially have referrals which don't reflect the expected level of incidence which we'd expect. And we also in some areas have over referral, whereby ultimately they are outside kind of standard deviation around what we'd expect. And sometimes that's around the appropriate use of cancer pathways relative to other elective choices. So what we're trying to do is to make sure we can get that sweet spot whereby the number of referrals, the type of referrals relates to the expected needs and outcome of the population. And indeed, that would mean in some areas whereby we have poor outcomes now, we'd expect those areas to be making more referrals to the patients who potentially in their patches do unfortunately have cancer. So we're doing that work. That's reflected in the work we do with each of the 5 West Yorkshire places, and we have a series of kind of corporate and clinical leads that help do that work. And we're also working with each of the place-based committees and local medical committees on that particular work. So that's a little bit more detail. That's what behind the actual paper, Councillor Hutchinson. But again, just to reassure that kind of focus and work is there. It's part of our strategy.
Chair, may I also ask?
Back with another word, yeah.
Yeah. As you say, we were involved in the review of the reconfiguration of the non-surgical oncology services. And I was wondering, and one of the main drivers for that was access to the appropriate specialist staff. What are the main challenges to improving the speed of diagnosis and treatment at the Leeds Cancer Centre, particularly? I know they obviously have a different range of case mix than you would do at the other ones, but how much of it is related to vacancy rates for non-surgical oncologists and radiologists and other staff that are required there, and how well is the training programme within the capacity of the training programme within West Yorkshire to actually supply the anticipated level of staff required?
So working on those questions, there is some, essentially the performance in Leeds Cancer Centre, generally speaking, tends to be lower on the cancer waiting times it does for the other sites, the reasons you described around the case mix. So what we do is to try and provide a meaningful comparison. We look at how Leeds Cancer Centre compares with other organisations of similar types or other cancer centres. And generally speaking, on that metric, it tends to do as well, if not better, than most of its peers. One of the reasons why it tends to have lower performance is because Leeds tends to get most complex cases, and the case which require the most complex treatment, and so it has the most complex patients go to its site. That's not directly accounted for in the performance figures, but again, it's just around comparing apples with apples. In terms of the bit around the non-surgical oncology work, Leeds has improved significantly its performance for radiotherapy in terms of the training provision of posts for post-tension evolved treatment planning, which is a major kind of challenge that they've experienced in the last 18 months. A lot of that's been around workforce redesign. It has been around training up posts and training up posts and supporting progression. It's also been around working together with other centres, and again, they've now got to a point whereby all the highest priority patients, and in there that means kind of categories A, B and C, they're all being routinely planned and receiving their treatment in 31 days, which is the national standard, which is good to see. In terms of the part around the bit around then the wider impact of the non-surgical oncology work, there is good progress being made in terms of development of the non-medical consultant roles to then help with the kind of what's being seen over time is more patients having cancer, more patients having more complex cancer treatment, and those more complex cancer treatment taking longer and further to deliver. So all those things have a kind of an impact on the workforce requirement, which is an increase. The non-medical consultants, especially recruitment routes, are going well. We have a number of specialist nurse development programs which are coming through well. Some good work with the deanery is, and we are starting to see positive signs of improvement. But again, I would flag it's certainly not job done in an SO. It is, it's a very significant challenge for all trusts, the ICB, indeed ourselves, but we are seeing some green shoots of improvement. Councillor Hutchison on those things.
Okay, Councillor Ryler.
Thank you. Thanks, Jason. And it looks like a really good positive picture. I was looking at the headline process on earlier diagnosis 2.0, where the report states that there's an improving trend rate demonstrated across the 4 of the 5 places in West Yorkshire, and it gives the uplift values rather than the actual values. I'm wondering whether there's much of a difference between different parts of different local authorities, and also, I mean, how do we fare internationally? I don't know whether you have any of that data.
Yeah, so
thank you.
Yeah, so the starting point rates, for want of a better word, is where they were in 2019. They were roughly in a range between about 51% and 53%. So there was that level of variation between the places. What we have seen is Kirklees and Wakefield catch up and indeed actually be more equitable with some of the places in West Yorkshire. And so we've seen a higher rate of improvement there than we have amongst the underlying rate of improvement in other places. In terms of how we compare internationally, some of this is in Lord Aradaz's report actually, but unfortunately NHS does not compare particularly favourably on early diagnosis rates with international peers. Particularly, we don't compare well with the Scandinavian systems, and we don't compare well with most of Western Europe. And I think some of the reasons for that is around, again, how quickly we brought innovation to the fore in the NHS, how quickly we've expanded diagnostic capacity, and also as well as around what are we doing to make sure that we have an engaged population that knows about cancer signs and symptoms. But I think the other element to it is around broader social policy factors, which then influence them, for example, around the underlying rate of cancer incidence. So, for example, the more we live healthy lifestyles and we have healthy environments, the more preventable cancers we will avoid. And so there are some differences between those international systems and our own, which does impact on some of these data. But again, to answer your question directly, there's some interesting analysis in Aradaz's report in terms of how we compare with our peers.
Yeah, thank you. Yeah. So maybe we need more of a sort of nanny state to try and nudge our population, so that maybe lifestyles can be changed.
I think so. I mean, from speaking from a kind of a Cancer Alliance point of view, I mean, we welcome, for example, what's coming through the tobacco and vapes bill. So again, for example, because that does have a positive impact on long-term cancer outcomes. Also, there's more political action, for example, on sugary foods, sugary drinks and fatty foods, etc. So again, we can't call for the nanny state as such, but again, what we can say is, you know, those things do happen to have a positive public health intervention, which will help cancer into the future.
Thank you.
Councillor Jamil.
Thank you, Chair. Thank you, Jason, for the paper. Really interesting read. You talked earlier about health inequalities, and I think Councillor from Leeds raised it as well. And I think some of my question has been answered, but I'd just like to sort of reiterate that about the minority screening, especially among the South Asian women. We do have that particular issue in Bradford. The screening rates uptake amongst that cohort of patients is particularly low, and it's just trying to get into the communities and educate them, and talk to them about the benefits of having that screening to enable us to improve the rates of early diagnosis and prognosis, etc. So I think there needs to be more work done around that, probably in other areas as well, but I know more so in Bradford, and some proactive work is being taking place at the moment. I know we've got an initiative in Bradford where there's been talks about going into faith organisations and talking to some of the men to try to encourage their sort of family women, their wives, sisters, daughters, etc. To teach them about the benefits of encouraging them to go for screening. And I think there is cultural barriers to overcome there as well, especially where some of the screening involves a little bit more intimate screening, like smear tests and mammograms and things. So it's trying to understand what these barriers are, why people are reluctant to attend such screening, and working to overcome them barriers and try to mitigate some of them in order to get the screening rates up and obviously increase them rates. So I think it's really encouraging that you are aware of that and you are acknowledging that that is a particular issue, but just to continue that work and try and be a little bit more proactive and taking that work out into the communities rather than expecting people to come into clinical settings and access some of that work. I think that would be greatly welcomed, especially in places like Bradford where we do have this particular issue.
So thank you for those comments, Councillor Jamil. Yes, I'd agree. I think we do, as the Health Service and indeed working with the screening commissions or other partners, we do have more work to do to not just rely on the population to kind of break down the barriers, but actually what can we do to actually make screening services inclusive, accessible, indeed personalised around the needs of individuals. Some of the work which isn't in the paper we are doing on that particular theme, we're involved in an academic collaboration at the University of Bradford actually around what are some of the barriers which actually impact on participation rates for cervical screening and breast screening coverage among South Asian women in Bradford and surrounding districts. And again, that's some kind of research that's being published, but it's also trying to influence for thinking nationally on that particular topic. One thing we are also doing as well, we have a number of programs which are trying to make a difference there. So we have a kind of a volunteer-led and indeed a kind of a peer-led Cancer Smart campaign, which again is actually allowing supportive members of the public to actually then have that conversation with people. So again, it's a kind of peer-to-peer approach. And we've also done some quite innovative work on social media as well, so using some Instagram influencers, again taken from the community, to actually have the conversation in a way which makes sense to and is indeed led by somebody, again, that colleagues and people in those communities will actually recognise and work with and they sometimes look up to. So again, trying to do some of that innovative work there too as well to make a difference, just to recognise, again, you are right to say that the underlying rates there of screening, participation, coverage are lower, and unfortunately that does exacerbate health inequalities, hence why we need to do more to make a difference.
Yeah. Brilliant, thank you, Chair.
Thank you. Would that research be published? Would it be possible for us to, for it to be synopsis circulated when it is published? I think people might be interested in understanding and how you're going to use that research.
Absolutely, we're happy to do both. It's that's a multi-year programme, but we certainly have to just publish the synopsis and what we'll do with it as well. Absolutely.
Okay, thank you. Councillor Bradbury.
Thank you, Chair, and thank you very much for the report. It's actually it's quite a positive reading on the whole, and say we know I've got a long way to go. You partly answered my question is in relation to the vaping part, but I suppose really what I'm interested to and keen to know is to what work is being done locally to raise awareness, because it's becoming a massive issue amongst certainly younger people, not smoking necessarily, but vaping. We don't know the full consequences of people vaping, and I just really wanted to know what is being done locally to raise that awareness, and almost, you know, it's almost looking back in the 50s when people started smoking, nobody quite knew the consequences. So it's really, you know, what's been done locally. I know we've got the bill which will go some way towards reducing that. Thank you, Chair.
So I think some of that particular work I think is very important. It's been led by the kind of tobacco control partnerships as well, being led at a place level. So again, that is actually just, I think that's principally trying to reiterate the message that the safest choice is actually not to smoke, and it doesn't really matter if it's tobacco, smoking, indeed vaping. And I think it's also those measures which can be profiled locally to dissuade and discourage vaping as being seen as an attractive alternative. And again, some of that you said is in the vapes bill around, for example, the way in which some of these products are being marketed, things like the flavours and how they're being profiled, and I think age-based restrictions on purchase and control and indeed availability. So again, I think it's fair to say that the local tobacco control partnership is supportive of all those measures. I think there's more work to do. I think there's more research needed, if I'm honest with you, in terms of the longer term impact of vaping, because I couldn't give a clear answer. I think vaping is seen as a harm reduction strategy compared with tobacco consumption itself. But I think ultimately, I think from a Council Lions point of view, we would be, you know, supportive of, for example, trying to persuade people to go to not smoking full stop, as opposed to seeing that as an alternative. Councillor Blackburn.
Okay, all right. Councillor Rhodes.
Thank you, Chair. Hello, Jason,
Hello.
and thank you for an excellent report. Some of the statistics within it are frightening when you think about 1 and 2 may be subject to cancer at some point. Some of the points I want to make have been touched on, but I'll be brief. National targets. How do we fare with any national targets? And I appreciate it'll be difficult up and down the country because of the location and nature of the industry where people work. It'll be different north than it is in south. That's the first one. In the second one, in terms of the paragraph on lungs, it's to re-invite the aged in and control group. Just a small explanation on that, but it also says in part of that you're awaiting through a procurement process. Obviously, I know the issue in terms of procurement. Is there a long delay in getting what you need, and is that affecting the service that you can give, Jason? That's the third one. And again, it's been mentioned here, and thank you for those. We're nearly on the same plane. Everybody, Howard's just mentioned it. You've mentioned it yourself. I see in the information as well, some areas across the West Yorkshire Joint Committee are on better stages than others in terms of planning. Do we have, Jason, information that can actually support what you're doing through the local places? Because, for instance, I don't know the circumstances in Bradford. I know the population. I know the in Leeds, etc. Every place is different. Is it something that could be done that would come to the local places, say quarterly or 6 monthly, where we could get it out there as well through our own committees, the value of having screening? And the other thing that's worrying me and a lot of people as well, there's a 62-day outcome that actually says about referral pathways. Now, the referral pathways, I'm assuming, Jason, you're referring to is from the first appointment to a doctor, and that starts the referral. Well, we all know that appointments are really bad. I mean, it took me, I was offered a month to get a blood test. But I know that there's some new doctors in place going around, etc. How do you communicate the importance of that first referral through the doctor? Because that comes out in the 62 days process. And the need for when somebody rings in and speaks to a receptionist, how to get across to that receptionist the need for an appointment, because sometimes, well, some are more urgent than others, aren't they? So when you're looking at your report here, you know, that needs to be set in there in doctors and GP practices. And public health. Now, I know that public health meetings from public health officers across all the places, they meet. And they meet with a representative. I don't believe he's a qualified public health officer that meets, but they get together and they have this information. Will that information that each public health officer has from their own place be advantageous to you when I go back and refer to 3 months or 6 monthly item on every scrutiny committee, reminding them of the importance of screening? And lastly, I wrote down here as Councillor Jamal was speaking, it's all about getting the message out to the community, and parts of the community who, for whatever reason, are reluctant to go through the process. I do recall, and there again, I've been around a long time, Jason, I do recall, like others, where we had the mobile X-ray unit that went to certain parts of our community, to that catchment area, to get people involved. And at the same time, on various sites, we had the mobile breast screening unit that could engage with the community. Is there, or could there be, a way of reinvigorating this as a catchment to get those people involved locally, rather than somebody having to think, well, I can't go there for various reasons. It can be lots of reasons, as Councillor Jamal has said, but you can bring that to the community where you know they're disadvantaged in some ways. And would that be something, Jason, that you consider, or has been, or could be considered as a way forward in the future?
Thank you. So I'll start on the last one first if I can. So the answer to that question is yes, we're considering it. What we've seen is there have been a number of successful awareness raising vans, basically, that have been developed in the Greater Manchester Cancer Alliance. So they do the same work that we do for the benefit of people in Greater Manchester, and indeed, unfortunately, have many of them the same health inequality that we do. One thing that they've actually achieved is basically a series of awareness raising campaign vans for particular cancers, which they've then taken to community locations to actually encourage people to come forward. And for example, you know, I was essentially on one of these vans of the week whereby it was about bowel cancer. And, you know, we saw a gentleman there who was actually coming up, actually concerned about to change his bowel habit, you know, partly because of, again, some work in the gym. And again, he was actually very concerned, but also was struggling to get through primary care. So very much similar scenarios to which you described, Councillor Rhodes. And what that actual van was able to do was actually give him some signposting awareness and advice, and also then give him what was called like a golden ticket, which then said, this is something which somebody has looked at and assessed and saying, actually, we do need to get this checked. And that simple statement was that helping get through that initial access barrier, which sometimes people experience. So we are looking at, you know, from West Yorkshire point of view, and again, I will say it's a proposal only, we don't have a procurement process for it set up yet. Can we do something similar in West Yorkshire? But also, can we build upon that model by having a qualified practitioner to have initial signpost advice on such a van in a facility? And to give you an idea where it was going to supermarket car parks. So essentially places whereby colleagues, you know, people from communities that don't traditionally come forward and might experience barriers, what we can do there. So again, that is part of our thinking, the early diagnosis strategy. You mentioned about the kind of targets, and so you're right to say that the 62-day target counts the time from when a patient is referred by the GP through to the time the first definitive treatment comes up. So you're also right to say there can be this kind of hidden waiting time, which is the time between when somebody first realises a symptom or it becomes of concern, to the point whereby then secure that initial entry point into the NHS, or on some occasions when they go forward for the first time, and then there's like a back and forth in terms of getting the right referral. There's some interesting research on that topic around kind of what's called the diagnostic window of appraisal, it's called, from Cancer Research UK, and that's looking at the significance of that waiting time in terms of what then happens to patient outcomes. And some of that research has been quite prominently shared in primary care settings. What we're doing with that research is building on the answer I gave to one of your colleagues, is where we're seeing differences in terms of the expected referral rate and the expected outcomes for particular populations. We want to use that research then say, well, you know, the primary care network up the road, which is not too dissimilar to yours, appears to have quite different rates of cancer referrals and cancer outcomes to yourselves. And there's some interesting research here on how they've made a difference. And for us, that's then kind of almost positing within those kind of settings and saying, actually, how can we use that research, that learning to make a difference? Now, some of that is by place, you said, but on occasion there will be sharing across the places, which again, we're very happy to support. In terms of the point you made around public health awareness, and for example, the way we're working together, and I can say from a Wakefield perspective, we do work with Joe Fitzpatrick and team in terms of their involvement in what's called the locality group for cancer for Wakefield, and that's trying to make sure that the secondary care initiatives, the primary care initiatives, public health initiatives are all being brought together under one umbrella. And what I mentioned in terms of the clinical leadership and the corporate leadership there is also trying to facilitate that work. We certainly would welcome any opportunities to share the campaign work we're doing awareness raising further. And we also as well are very both happy to share the data we have and the data our public health colleagues have as well to kind of profile and make a difference in terms of these types of areas of work. You also mentioned about the lung cancer screening work and what I meant by ageing in and things like that, and recommissioning procurement. So what I mean is that the lung cancer screening work essentially, as it was called at the time, targeted lung health checks, the same thing with a different name. That basically was picking up people who were aged between 54 and 75, I believe, at the time whereby those invitations were made. And what that was looking for was a trawl of primary care records for people who had a smoking history, and then therefore there was somebody who might benefit from a check. And the people who were brought forward there were those who, for example, had not had a cancer, but indeed were either a current or a past smoker. What we're aware of is obviously we're now in 2025 and that programme will continue to the end of the decade. And so those populations which were in their late 40s and early 50s at the time were not eligible at the time the programme started, but now are eligible on their age. And so we will re-invite those populations in. The specific comment about the control group is specific only to Leeds. It doesn't refer to any other place. And that's because Leeds started on something called the Yorkshire Lung Screening Trial, which was a clinical trial comparing the benefit of the intervention with the control group, which is an unscreened population. So what we're also doing through Leeds as well is to make sure that those populations initially put into the control group also benefit from the same clinical intervention that the intervention group, indeed the aging group, do. The other element is that there are small numbers of people who have moved into West Yorkshire since the programme started who might not have had a benefit elsewhere, so we're giving them a further opportunity. And so what we're trying to do is to make sure that in realistic terms, by the end of the programme, the entirety of the West Yorkshire population is covered. It's not by default what age somebody was when the programme first started in their geography. I think I've answered all the points there, but I'm just mindful I might have missed one, so please remind me if I've missed one.
You have indeed, Jason, but there was one thing I was waiting for. I was looking for some information further up until I got down to the graph in terms of prostate cancer.
Yeah.
When I look at that graph at current early stage, etc., I can see that the volume in terms of percentage has actually increased over the period of time, which is good, because many years ago, cervical cancer was the norm of inviting ladies, but there was very little said about prostate cancer. So this actually looks in percentage terms as though the message is getting out there to the men folk as well to go get checked.
Yeah.
And thank you for the report, Jason. It's great.
Thank you.
Okay, and in your report, Jason, you mentioned about sharing details of your public awareness and campaign work for the early diagnosis, so that we can distribute that if we wish via our own networks. And I think if the committee, we would like to have that information. I think would the committee indicate Yeah,
very useful. Very useful.
Yeah. Okay. Thank you, Councillor Hutchinson.
Thank you. You've already referred to some of the cultural barriers in the cervical screening programme. Are there similar cultural barriers to HPV, human papillomavirus vaccination, within those communities? And I was just wondering more generally whether the Alliance, how much use the Alliance makes of the school nursing service in terms of discouraging smoking, pointing up the health impact of that, but also the health impacts of obesity and other risk factors. Is that something that there is much direct connection between the school nursing service and the Alliance?
So, to answer the first part of the question, yes, there are some of the similar barriers around HPV vaccination, and indeed kind of general attitudes towards screening, and indeed some of those barriers are the same to other forms of vaccination, and we do see similar levels of population behaviours. Again, they require the same response. The other side of it, yes, we do interact through some of our health and equality programmes with school nursing. Some of that work, I would say, is also delivered by the screening commissioners who kind of work on that service on kind of a regional level. So again, they are trying to make sure that from an early age, as part of of school education curriculum, we are outlining the benefits of actually having healthy lifestyles, and actually, and interestingly as well, our Cancer Smart colleagues in the Yorkshire cancer community, they have actually done talks in schools as well. And the reason for that is we're also trying to influence the children, trying to influence the conversation that happens at home.
Yeah.
For example, around, how those children might deposit some of those messages with their parents.
Absolutely.
Yeah.
Okay, thank you. Are there any other questions for Jason? No. So you've said at the end in your report as well about further discussions, including the lung cancer screening programme developing into a national scheme. I think yes, we'd like that as well. So if I could just summarise, then we talked about targeted screening, and you were going to share some data on that. PCNs, the work there, and the training for staff and Leeds Cancer Centre. We asked questions around that. Early diagnosis rates across places, international comparisons, barriers to screening, particularly HPV in South Asian women were mentioned. And on the latter, you're going to share a summary of the research and what's going to be done with it when that's available. We talked about vaping, national targets, and referral pathways and the barriers to access and how those can be overcome, public health work and community messaging, public health campaigning, and school nurses and schools discussions. Have I covered everything there, everybody? Yes. Okay, so thank you, Jason, very much for coming and talking to us today. Thank you.
Thank you. Bye, everyone.
Thank you,
So
Jason.
we'll move on then to item 6, the work and health plan and programmes. And Jennifer, I think, is this yourself that you're going to introduce this item for us, please?
Yeah, morning everyone. My name's Jen Connolly. I'm Associate Director for Improving Population Health. I work jointly between West Yorkshire Integrated Care Board and West Yorkshire Combined Authority. So really pleased to bring this report forward to you today. and hopefully everyone's had a chance to read it. I'll just run through some highlights from the report and then really welcome your questions and comments. So this work really aligns with the 10th big ambition of the ICB around the NHS's role in social and economic development, and it's something that we've been committed to for some time across West Yorkshire. We've been working closely, the ICB, with the combined authority on the work and health agenda, really bringing in all the expertise from our local authorities and in partnership with the DWP as well, through a work and health partnership that we've had in place since September 23. Through that, we commissioned activity to really get insight from our communities, and that work then informed the joint work and health plan, which was published on the 10th of March 2025. So that insight gathering has really informed the work that we've been doing so far. So alongside that, we then had the national announcements through the Great Britain Working White Paper. And part of that were the 2 programmes that we've gone into a little bit more detail in the paper. We've got an accelerator work and health programme, which is the responsibility of the ICB. That's to the value of £11 million for West Yorkshire. And we have a trailblazer programme, which is the responsibility of the combined authority, and a total amount of £10 million for both of those funding opportunities for 1 year, for 25-26. We know there's also funding coming to the combined authority under the Connect to Work programme, which is for a little bit of a longer time scale, but very much related to the same sort of work. So we've pulled those things together really under that work and health plan, and we've pulled those programme opportunities together so that we're really trying to maximise that opportunity and get the most amount of impact and learning that we can across this financial year. So it's really taken a lot of system working across the last few months to get us to this position. We've got signed off plans from NHS England and from DWP, and activity happening from April onwards. So if I just go back to the joint work and health plan for one moment, and then I'll come more detail on the accelerator work. But the plan talks about 5 key objectives, one around strengthening that health, employment and skills system leadership across the patch, so that we have that oversight, better informed decision making, bringing together the ICB, combined authority, local authorities and DWP. Another key objective from the plan is around understanding and addressing the barriers that our small and medium enterprise businesses take, the barriers that they have in taking action to better support the workforce. Thirdly, we want to look at incentives to support more people into work. We also know that continued backing of our voluntary community and social enterprise sector is really key, both as delivery partners and key in engaging with the populations that we want to reach through this sort of work. And then finally, we know we need to do more to develop networks to support people in working in this way and working jointly. So we'll have networks that support the business community, networks that support people offering the services that we're putting in place, and so on. The paper that you've seen really describes how we're moving to delivering on those programmes that we want to underneath that banner of the work and health plan. And if I give specific attention now to the accelerator part of that £11 million that's the responsibility of the ICB, we've worked with the place leads in each of the 5 places of the ICB to develop specific intervention plans for both to target the key population across the patch, but also then specific work for the health and social care workforce in each of the 5 places. That's been really informed by the data that we have developed in line with principles that we've agreed across the system. So the model that we've taken here, in line with the principles of subsidiarity, are to set a framework, and then each of the places design the specific interventions and activities that are needed, relevant to your population, what we know about the demographics of those who are struggling with economic inactivity in each of those places. So it's funded to the places based on in a way that we've allocated that based on need rather than based on just a sort of headcount approach. It's equitably allocated based on the proportion of economic inactivity due to ill health in each of our places, and that means the way we've done that means that we're looking to address the inequalities faced from the outset, and that's also been explicit in the framework that we've allocated to places. So in terms of the types of activities that are going to be resulting from this work, our health and social care workforce will see increased capacity and improved connectivity across health coaching, work coaching and social prescribing. They'll also see increased access to fast track sector specific services, for whether that be for guided self-management, professional assessments and also first stage therapies around musculoskeletal conditions and other cardio and metabolic conditions. That might include pain management and neurodiversity as well. They'll see mental health interventions, including fast track offer there, and also developing the wider offer under the workplace promise. So that's more to do with the culture and the policies that we have in place, and training offers and how we're supporting people more broadly who are employed in that health and social care workforce. Then for the wider population under that prevention and early intervention sort of banner, the offers, again, there'll be variety across the patch, and we're really proud of that because it's really led by our places, by the populations and what already exists. But the types of offers which we'll be looking to target to support people to stay in work through managing their own health conditions. The types of services will be things like increasing our rehabilitation offers, particularly vocational rehab, which looks at how you support somebody to think about managing their condition in the context of their wider lives, which will include work. How we increase our support for unpaid carers who are disproportionately affected in this way. How we expand our targeted offers for working age adults to stop conditions declining or to stop further conditions developing. So we've got things like exercise referrals, for identifying more people with high blood pressure, with hypertension, and more health check offers. We'll also have support for people in managing pain, because we know that there's a myriad of sort of conditions that can lead to people falling out of work due to ill health, but often some of those symptoms are common across conditions. So thinking about the symptoms like pain and fatigue, taking that approach is really important here. There'll also be increased mental health support and improving access to talking therapies and IPS, which is individual placement support, which is quite a specific model of supporting somebody into work and supporting their conditions. And we'll have waiting well approaches, particularly thinking about those on ADHD and other planned care waiting lists. Our VCSE support offer has been key to this work, and we've also looked for opportunities to link this to the Creative Health programme that's across West Yorkshire. So as I said before, we're really proud that we've got this really diverse offer, and that's been really led and designed by our places. And we've used the insight that we gathered from the communities in developing the work and health plan to inform those offers. So our target throughout this is to support 1,300 people across West Yorkshire to remain in work who would have otherwise fallen out of work. So we know that the trajectory of people in economic inactivity due to ill health has been growing. So we're looking to stop the growth in that number, and the target for us is 1,300 across West Yorkshire. It's 1.2% decrease in what we would have seen otherwise. And that's going to be our focus throughout. Whilst we really remain steadfast on delivering that target to reduce that growth, we're also really seeing this year as an opportunity to innovate to learn, to develop our approach, which is about the joint working as well as the sort of very, very specific work, some of the specific work that I've mentioned. So that joint working across the combined authority, local authorities, DWP and the ICB, we're really thinking about that different way of working with central government as well. So that way of working has been well reflected in the programme board governance that's in the paper. We've got a programme board already established, and we're looking to establish a strategic board to guide this work as well. There are some challenging risks to contend with in this programme. It's been set up at breakneck speed, and we've worked really, really hard and fast to get that going as quickly as we can. But we do have a really strong vision for change and clear outcome target that we're looking to achieve, and partnership working that puts us in really strong place on this. So yeah, I really welcome your questions, and yeah, look forward to hearing your thoughts. Thank you.
Thank you. Are there any questions for Jen on this? Councillor Hutchinson?
Thanks, Jennifer. I had anticipated that the target of this was to actually get people into the workplace, not just preventing them from falling out of the workplace, although that's important. Have I got that wrong?
Overall, we want to do both. The focus of the accelerator within the context of the other programmes that I mentioned is more about supporting people to remain in work who would have otherwise fallen out, because we know that number is growing. So we need to both stop that number growing by preventing people from falling out, and we need to work with the populations who have already fallen out of work, and that is definitely part of the Trailblazer and the Connect to Work programme. So it's both. The focus of the accelerator trying to be on the more of the prevention end.
Okay, can you say a little bit more about the support for employers? Because obviously, if you've got somebody who is, some days they're fine to come into work and other days they're not, so they're intermittent attendees. That can be incredibly disruptive, particularly if they're working at a key point in the organisation. It's bad for small and medium enterprises, but it can equally be bad in small teams within larger organisations like NHS trusts. So what support are you able to bring in to give employers the confidence to go at risk by keeping on people who are not consistently able to perform at work?
Yeah, no, it's really key to this work, and there's a few different routes to that. Some of the direct work with employers that will be done is looking at things that are like reasonable adjustments, sort of making people more aware of what offers are already out there, making employers more aware of how to use those successfully. But we're also, in the work that we're doing with individuals, really trying to empower people to have proactive conversations with their employers, to be able to say, look, this is the kind of thing that will keep me well and enable me to be more stable. And also, through the work that we're doing with individuals, help them manage their own condition better to become more stable. So it's kind of a few different ways that we can look to support. And there's a few networks that will be in place to support employers with that, including things like the Fair Work Charter that we have across West Yorkshire. And I know that in each of our 5 local authorities, there are really strong networks with employers there, and there are different arrangements in place already. So we're looking to route those conversations through the Employment West Yorkshire approach that we've already got across West Yorkshire, so that we can make the most of those relationships and have access into those employers. So that we're trying to do both things. We're trying to speak to the employers, upskill there, so knowledge, skills and confidence in managing those conversations and what's possible, and also then working with the individuals to empower them to have those conversations directly with their employer.
Can I just ask about the mental health support. The outcomes from talking therapies are they're not brilliant. So what other aspects of mental health support are you engaging other than fast track to access to talking therapies?
There's a few different things depending on the locality plans. So there's a variety depending on which locality that we're sort of considering, and that's been based on what the local provision and need already is in those different areas. So that might include the talking therapies that we've already mentioned. It also includes thinking about the sorry, just let me get the detail up. We've also got things like some of the VCSE offers that support people who wouldn't necessarily have criteria for an IPS, individual placement support offer, but we can do more in the local, through the local VCSE offers around mental health support there. So that's one example of the types of things that are being explored. And secondary to that, the work that we're doing with employers on thinking about policies and culture and workplace environment is more broadly supportive of mental well-being in its more general terms as well.
But no expansion of clinical mental health services. I know it's difficult.
Not directly.
I know it's difficult in a one-year programme.
I think that's the challenge. We've been looking at things that we can stand up swiftly, really have the impact that we want to see, and also be able to deliver within that time frame.
Okay, all right, thanks. Councillor Ryler.
Hi, thank you. Thanks, Jennifer. Yeah, I'm definitely with you on this programme. But I sort of have my doubts about how it can be successful. I think a lot of this, whereby people are out of work, ill health, etc., is inequality, poverty, people that find themselves in those situations. For example, it may be that for those people, their jobs are manual jobs. They're not, like we do, sitting on Teams meetings, and so it has a greater impact on them in terms of their health. So, in terms of sort of things like musculoskeletal issues, etc. So it's sort of more difficult maybe for them to go back to work. Mental health as well. Then for a lot of people, their mental health is not going to improve necessarily. A lot of it is and I know this sort of from people that I know that work in the business, is situational. And you think, well, okay, I understand why maybe that person has mental health issues because of their ill health, because they live in poverty, because their housing isn't that good. So these are, I guess what I'm saying is these are huge issues that we're addressing. So I'm wondering, do you have any examples of sort of best practice where maybe where maybe some employers have managed to work around this, or other organisations or other communities have managed to engage and have been successful? I just wondered whether you had some examples.
Yeah, no, you're absolutely right. And I think you've touched on the importance of why it's so important that we work in real partnership on this, because we need the kind of DWP offer right, we need the employment support right, we need, and those wider determinants, those wider factors that impact on people's health. I think what we're seeing a shift in is the people really recognising that good work is a health outcome. So good work is good for your health. And we need to see this as it's that two-way street, isn't it? We need to improve people's health to enable them to be able to function well at work, but we need to see good work and the sort of quality work as a health outcome as well, and that importance on helping people to remain healthy, whether that be through the kind of lack of isolation, through improving connections that you get through work, and the focus on being productive and having purpose, those sorts of elements. And that's something that we're considering through this programme. In terms of the good practice, the evidence base on the health interventions for as an economic outcomes is really limited. So that's part of what we're developing through this programme. We are working with the 3 other areas across the country that have got the accelerator funding, and those who are doing work on work well programmes, which is another sort of a previous funding stream. And we're working through with the combined authority with the other areas across the country that are doing the Trailblazer activity as well. So I think we are absolutely using those networks to learn and share, and using the evidence base in our practice. I think what's lacking is the evidence base that specifically relates health interventions to economic outcomes, and that we're part of developing that over the course of this year as well.
Okay, thanks.
No, thank you. If I can just say, I am with you. I am supportive of what you're trying to do. I just think it's difficult. Yeah, thank you.
And I think that's reflected in why there's quite a lot of investment, and sometimes you can see it as a relatively small figure in terms of the target. We know this requires a lot of work, a lot of investment, and a lot of that joint system working, and really thinking about whether you describe it as a person-centered approach or a biopsychosocial model. It can be described in different ways, but it's just really thinking holistically for an individual. So we are really focused on the join up of our services, not just thinking in kind of clinical pathway terms.
Can I just ask as well, you've got this money that you need to make the maximum use of to get people or to keep people into work, but what about the sustainability moving forward? How are you making sure, so when the money runs out, where is the support for people? Because their need doesn't stop. So how are you going to look to make it sustainable into the future?
So the funding at present is for the accelerator and for the Trailblazer, our single year funding. We are aware that NHSE and DWP are putting into the spending review requests for that to be extended.
Right. Okay.
Obviously we don't know the outcome of that until the spending review, but what we have been conscious of in standing up our activities is making sure that we've got a really clear kind of exit route for that. We will absolutely maximise the opportunity to learn through this year and look at where we can change services going forward to build on the learning of this, even if we can't maintain them at the scale or level that we have been through this year. So I think we've had that kind of in our minds from the outset of this.
Right. Okay. I think it's how you mainstream, you know what I mean, how you mainstream money that comes in. That was my
absolutely.
That was my thinking, But anyway, Councillor Rhodes.
Thanks, Chair. Now, do forgive me if any of this that I'm going to ask at the moment has already been said, because I've been offline for really 4 to 5 minutes. It just all went dead. And it's not my system because my daughter went and checked it. So there's something drastically wrong this morning with our connectivity. Hello, Jennifer. Right. Councillor Ryle and Jane has started off the conversation, which is very valuable to this, and Councillor Smage has added to it in terms of the long-term position. Forgive me, I'm going to ask questions that you mightn't have the answer for, but I'll appreciate it. Then you can send it back to our chair. You've got £11 million and there's an expectation of supporting X amount of people. How much of that is revenue Is it new posts or is it existing posts that have taken on the work? So how much of the revenue has been taken out of the 11 million? Because that then reduces your financial stability for over a period of time. I note that you have actually presented a pie chart here today, which seems to indicate national information. And obviously, when I've looked at it again, it's very interesting to see what the elements on that are in terms of the issues that you've spoken about, in terms of ill health, et cetera, And one of the national averages here seems to be on mental health. Councillor Smage and a lot of us here today, we've been speaking about that in our own areas. My question following up from this is, where have you, through your work up to press, actually investigated in a West Yorkshire pie chart? Because that in itself of the information you've got is helpful to us back in place for any discussions we might have. We can't just go on the national one here, but the West Yorkshire pie chart would be very, very useful, because somehow you've actually accommodated division of the 11 million to information that you've got each of the places. So you must have some information that would put together a pie chart for you. Has that been looked at, Jennifer? Because that'd be useful for us in our own committees as well. And the obviously the proportion of the economy in terms of people.
I think Councillor Rhodes is frozen. So could you just answer the questions that she's posed until she comes back? Yeah.
Yes, certainly.
Will she not just ask? Sorry, Chair. Will she not just ask him again?
Yes, she can. Yeah. But this particular about the information she was asking for about in place and the split of the money. Could you just address that, please?
Yes, certainly. So the 90% of the budgets have been delegated to Place, and Places have then commissioning the relevant activity based on the plans that they've developed.
Okay. So that information could be sent to the committee as to for the places. Yeah. So the place committees could ask for that information. That's what I'm getting at.
Yes.
Yeah. Okay, Councillor Scopes.
Yeah, thank you very much, Chair. I'm just picking up on what's been raised by Jane really well, I think, about the wider determinants of health. And I think that's really true. And we've talked about this a lot in Leeds, and how something like in Leeds would talk about 40% or 20% being health and the rest being wider determinants. And so I just wanted to know so I've got two questions. One is, are you linking in with the Marmot City stuff we're doing in Leeds? And I think that's an important aspect of trying to uplift the wider stuff. And some of it's not specifically health stuff, like housing, like education, all that sort of thing is much wider. And then the second question I have is around innovation. So, for example, there's a small wood recycling charity, CIC, in my ward in Holbeck in Leeds, and they did this get people back to work scheme, where you learned a skill, you got a certificate to work on a site over like a 3 to 5 week process. And I think there's something around like enabling people to think, oh yeah, I can be part of this. And I think there's lots of ideas like that, not just in my area in Leeds, but across West Yorkshire. And I think there's probably something around trying to sort of invigorate that sort of innovation, and how do we change like the system so those sort of small innovators get a piece of the pie, as it were, rather than doing it just off their own back. Yes, those are my two questions. But thanks for your report, Jennifer.
Thank you, Councillor Scope. So in relation to the connection with wider activity that's going on across, absolutely. And we've tried to bring that together. So we've got a joint programme board that really focuses on the delivery of these programmes across West Yorkshire, but we've really sort of encouraged locally that join up to be replicated, so that in Leeds, where you've got the Marmot City work, that can be factored in, and each area will have slightly different context and other activities and programmes happening. I'm very happy to connect you with the lead in Leeds, if that's helpful to just understand the details a bit more. I can share the contact details for each of the 5 lead officers, so you can get in touch and understand the detail in each of the places a little bit more. More broadly about the example you gave, the work and health plan absolutely recognises the value of our VCSE sector and some of these sort of smaller, if you like, initiatives in how that can contribute to people's health and well-being, and therefore their routes back into work. And that's been picked up through both the accelerator funding. We can't fund everything, but that's certainly been recognised, but also in the Trailblazer and the Work and Health Plan, really committing to find routes to the VCSE with this sort of work. So I think there'll be more coming on some of the Trailblazer activities with the VCSE as well, but that's been one of the key principles that we've put within the framework that we've set out.
Okay, Councillor Scopes. Yeah. Okay. Councillor Rhodes, are you back with us? Oh, I think she was. Councillor Rhodes was with us for a little while, but I think she's gone again. Maybe we could ask Councillor Rhodes to provide some questions after the meeting, and you could circulate the answers.
Certainly.
I think there's technical
one
problems
about,
this morning. Yeah.
There was one about some data requests as well, which I can certainly share.
Right. Okay.
Some key data there.
That's brilliant. Councillor Soloway.
Just a very quick question. Are the NHS involved directly in this in terms of their own practices? The reason I ask is because recently North Yorkshire are developing an autism strategy, and we've had a number of people coming to our meetings talking about autism. And I asked the direct question, how many people in your organisation do you employ who have autism or on the autism spectrum? And they didn't have the data on it. They couldn't answer my question. And I'm just hoping that the NHS is also on board with this, with their own support of their own employees, because sometimes I hear other stories that maybe they're not.
Yes, absolutely. And we've set that out as our kind of pillar 1, if you like. That's our framing of it, but that's a real focus on the health and social care sector, so our own workforce, and there are some slightly different offers because it's sector specific, really thinking about our own workforce and what that can be, both the kind of service type offers, but also thinking about the policies and culture and practices for our sector specific health and social care workforce that we're looking to build on some of the work that's been done through the People Promise and Career Compass and things like that, but really looking to spread that across the West Yorkshire NHS and social care employers.
All right, thank you.
Okay,
Good to hear that.
Now, Councillor Rhodes, I think, are you back with us? So if you have another technical issue, Councillor Rhodes, what I suggest is if it breaks up again, let us have your questions and we'll get the answers. So let's have another go, Councillor Rhodes. On mute now. Councillor Rhodes, you're on mute. I'm sorry, we can't hear you.
I've been around the houses this morning. Hello, Jennifer, I'm back. Sorry, dear. My last question was, you mentioned about the revenue that's taken out of it, and Councillor Smage quite rightly put to you the long-term issue. So I know you'll be coming back with an answer on that to Councillor Smage. Now, I mentioned about the place leads and the pie chart that would be helpful to us all in terms of the accelerator and how it's working together in our own areas. That's very important. But the other one that you mentioned is social prescribing and the involvement of the VCSE. Now, could you just enhance that a little bit in terms of how you approach that? What examples have you had? Because I think Jane asked the same question. What examples have you had of that being on the road to success? And indeed, any of the success stories that you've had, and do forgive me saying this, I think there's a value to a job out there to make somebody feel better about themselves, because sometimes some of the employment offers are still having people going out there to food banks. So you can't give them a job that isn't paying enough while somebody has to be directed to food banks because one does not enhance the other. So that's my questions, Chair. Thank you.
Jen,
yeah, thank you. Yeah, so we've really recognised the role of the VCSE in this work, and it'll be slightly different in each place depending on the infrastructure and the organisations that are there doing good work already. But there are a number of commissions directly with the VCSE through this work, and that's also committed to in the Trailblazer work, where we're also going to be further funding that offer. This focuses on the kind of the health intervention model, and the Trailblazer more on the kind of employment support, broadly speaking. And then I think in terms of the kind of the learning, the data, I will absolutely be sharing that. In terms of what you described about the employer side of things and the nature of good work, I think that's something that we're really looking to pick up through this Trailblazer activity as well, working with our employers, but also more broadly our Fair Work Charter. So that really looks to enhance the amount of fair employers across the region, and we've seen good growth in the number of employers signing up to that. We'll continue that work, and there's real ambition for that to grow over the coming years. Those networks that the Fair Work employers are getting access to, helping support each other, there's some fantastic practice coming out of that. But that's part of the combined authorities' wider role in economic development alongside the local authorities, and how we grow that engagement with and understanding of good fair work across the region. And then you talked about the sort of importance of a kind of coaching model, I think, in there, and that's certainly something that's part of this offer, working to empower individuals, because people taking control of their own health and life and being able to embrace those conversations with their employer to help navigate the challenges they might face. That's been shown through the work we've done on rehabilitation, vocational rehabilitation. That's really proven very effective in supporting people to stay in work and come back into work in certain circumstances as well.
Chair, I thank you for that, Jennifer. And having been through this quite a while, and I do sit on the WICA, and I welcome the work that you're trying to do with this funding. But I'm sorry, do forgive me saying this, and it's not intentionally personal to anybody. There's lots of buzzwords that come out, and when we get behind them, it's very difficult to know or to try and trace what's been actually evaluated and what works. And it is something that's got to be considered in terms of the Fair Works Charter. Now, would you like to tell us a little bit more about that? Because some people, and we experience them in our own wards, and they're not behind any kind of buzzwords, they're behind certainly a low esteem, poor expectations, because they're not supported in many ways to go further. And I'd like to know about the Fair Charter in terms of who's signing up for it and what is the criteria expected of a Fair Charter employer.
Yes, certainly. So the Fair Work Charter doesn't have a kind of minimum requirement. It's about the progression of the employer. So there's not a threshold for you joining, but there are a number of criteria that you can both say you're already working at and then continue to develop in. Because we didn't
sorry,
want this...
Jennifer, when you say you, do you mean the person or the employer?
The employer. So the Fair Work Charter is aimed at employers across the region, and employers can sign up to say that they are a Fair Work Charter employer, which looks at a number of different criteria about how they support staff, the networks that they have involved, that they have established through their work, the way they engage with trade unions, the engagement of staff in the voice and representation that staff have in those sorts of things, as well as maybe well-being offers and some wider metrics indicators. When an employer wants to sign up to become a member of the Fair Work Charter, there's a form for them to fill in, essentially, and it asks them to demonstrate how they are meeting some of these criteria. But we don't have a kind of threshold where you have to meet, let's say, 5 out of 50 or something, or 10 out of 50 to get that accreditation. It's about the journey that employers are wanting to make. So it's it's an open and encouraging, supportive approach that will take more people on that journey.
Okay,
so that's the employer side of things.
Apologies, my silly phone is at it now. But anyway, that's really good to know. But it's disappointing to know that they may not have any baseline to call themselves a fair charter. But do you have any kind of monitoring, Jennifer? I think it's important if we break down the pie chart to our areas, and we know of people in our community where we have X amount of fair charter employers, it would be useful to say, go and make inquiries about A, B, C, or D, because we know they're a fair employer.
So that's really where the employment support offer comes in. And across West Yorkshire, we have Employment West Yorkshire. It's got slightly different names in the different areas. So working with through the local councils and your employment advisors can really help with that connectivity into helping people think through what's the right kind of employment for them, thinking about skills and what's going to be expected of them in that employment. And so that's why the join up with the health offer and the employment offer has been key to what we're bringing forward in our plans.
I think it's a great experience, Chair, and I do hope sincerely, as Jane pointed out, and you have, that the Fair Charter is a fair charter. It doesn't sound as though anybody monitors the system. It's expected of somebody else. I do know within our authority, and this is why I'm asked the question, and I'm sure in our own as well, we do have a skills operative in terms of the authority. I don't know how you're going to produce, or if you can produce, a pie chart for the authorities as I've asked, because we can see there individually where that 11 million or 85%, or well, it'll be 15% of the revenue is gone. We could actually see then within our own authorities, and take it further on the health agenda, how we can involve people locally as well. So that would be good, Jennifer. Thank you for your report.
Okay, so just before I summarise, could you just tell us your strategic board, how are you getting that in place and what's your time scale? Because you're quite a way down the line on this, aren't you? And is there any point where you're going to have a look to see if there's any areas where you really need to concentrate further in as part of the 12 months, or whether you can continue with the same broad span of support?
Yeah, great question. So we were reviewing what governance options we had for the strategic board or committee, and we've now got some governance advice on what form that can take. So we're looking to get that set up in the next couple of months. We're just on with that now that we've got a way forward. And in terms of the learning and sort of course correction as we go, we've got quite clear monitoring arrangements with NHS England, and that will be taken through the sort of joint programme board and strategic board to assess how we're progressing across the year. And we're looking at different sort of monitoring metrics that we can use to help us understand that. We're expecting that the majority of what we're going to see will be later in the year, because obviously we need to get these things up and running. So we know that the first part of the year will be somewhat lower in terms of volume, in terms of numbers that we'll see. So we've got a plan for the year, what that will sort of look like across the year, and if we see deviation from that, then we'll have to really look at where we change, what we learn from other areas, because, you know, as I say, we're proud that we've got slightly different offers in different areas, but the opportunity here is really to learn from each other and to shape different offers going forward. So that's the intention of the work through the monitoring of that programme board.
Okay, that's great. Thank you. So there were a couple of things then, weren't there? So you were going to let us have contact details for place so that the place committees can get some more details locally, and you're also going to get us the figures and how that 11 million has been split down by place, or a contact as to where the place committees can get that information. Okay, all right, everybody, thank you very much for that item. We just have one more item, item 7, amendment to the memorandum of understanding, if I can get my words out, and it is just paragraph 46, a slight addition to that, in case we need to review the working of the memorandum of understanding before the slightly before the 12 months. This is just in case of. Is everybody all right with that amendment? Yes. Okay, thank you ever so much, everybody. And that brings us to the end of the meeting. So can I say this is the last meeting for this municipal year. We'll move into a new municipal year after the annual meetings in May. So thank you, everybody, for your attendance at the meetings and your very valuable inputs and questions. Thank you so much. All right, thank you.
Thank you, Chair.
Thank you. Thank you,
Bye.
Chair.
Thank you.